Good morning, everyone. Welcome to the Ohio Chapter American Academy of Orthotists and Prosthetists, their spring conference. The title of this presentation is Individuals with Stroke Speak About AFOs. We need team talk for a better walk. I am Dr. Jennifer Brown, and the research work was done at Ohio University. Again, welcome. This research was funded by the Ohio Physical Therapy Association and the Ohio University Research Council. I would like to give special thanks to Dr. Stephen Best, my research assistant and then student who is now working with the Pittsburgh Steelers, and Dr. Julie Sir, who's in the Department of Psychology. I just want to share some disclaimers and definitions. The pictures of the AFOs in this presentation are not those of the participants. I did not get permission to share their pictures or videos in any public forum. Individuals with stroke is IWS, healthcare providers, HCPs, and you'll see the words impairments, but impairments may represent decreased strength, decreased range of motion, loss of sensation, proprioception, or spatial awareness at the body structure function level. Impairments at the activity level will be walking. So these are the objectives for the course today. Upon completion, you should be able to explain the relationship between AFO use and illness perception, differentiate between the value of motor recovery versus functional mobility as represented by the AFO, and consider topics that need to be communicated among the individual with stroke, the caregiver, and the physical therapist, assuring that there is shared decision-making so all of this information shared amongst these three individuals can be communicated appropriately to the orthotist. This is our outline. We'll go to the study background, the study purpose. We'll review the methodology, the results. We'll have an in-depth discussion about the themes that were generated from the research. I will mention the study limitations, end with a conclusion, and then say some ideas for future research. So for the study background, stroke-related disability impacts daily living activities and participations, which may involve parenting, employment, and other social roles. Leg weakness is common, often requiring an AFO. The AFOs are designed to keep the foot up in swing phase and to stabilize the ankle during stance phase. If needed long-term, the AFO represents that the body may not return to normal as people think normal should be, and the perception of chronic illness ensues, despite that people are able to engage in a functional activity, which is walking. The AFO requires a larger shoe and often limits the choices of clothing attire, including shoes, which devalues the power of choice by the individual with stroke. So what was the purpose of this study? I wanted to get the opinions of individuals with stroke regarding AFO impact on stroke recovery in terms of functional outcomes, which is walking, and then versus impairment. And for this particular study, it would be weakness. More specifically, I wanted to know how the AFO contributes to body functioning as an object or as a part of a process for social interaction. And when I say part of a process for social interaction, you have to go through different movement sequences and patterns in order to engage with your environment. So not only do you have to walk, but you have to turn, squat, go up and down stairs, sidestep in a pew. So you function more in a process to do things as opposed to just an object of an endpoint in order to accomplish one simple thing, like pull your foot up. So the methodology, I chose the theoretical construct of phenomenology. We use phenomenology to determine how the individual with stroke understands and gives meaning to the process of getting an AFO, wearing it, and discussing with orthotists and physical therapists issues impacting daily living. The participants were ages 30 to 65 and currently wearing or have worn a custom hinged or solid AFO. I recruited subjects from 43 Ohio counties with or in proximity to a primary or comprehensive stroke centers. I just felt upon discharge, I would have a vast array of participants to send information to, or their primary care physicians or other healthcare providers, in order to use those individuals as gatekeepers to give the information to individuals with stroke. The healthcare providers distributed the flyers to the individuals with strokes, and particularly these were some criteria. The individual with stroke had to be diagnosed with a unilateral stroke within 1 year, and if it was more than a year, they have no memory compromise, and they had to use an AFO for at least a month, and they had to walk at least 10 feet. So this was the data collection process. I performed semi-structured interviews based on the SHOWed method. And the SHOWed method is this: what do you see here? What's really happening here? How does this relate to our lives? And in this case, it would be the life of the individual with stroke. Why does this problem exist? I was seeking some self-reflection if the individual with stroke could say what was the problem with the AFO, what was the problem with them wearing the AFO, if any, and what was the problem with them wearing the AFO while doing an activity? And then the last question is, what can we do about this? So in order to answer these questions, there was a picture of the AFO by itself, and then there was a self-portrait of the individual with stroke wearing the AFO, and then there was a video of the individual with the stroke performing an activity while wearing the AFO. So the individuals with stroke looked at the pictures or video while answering the questions during this semi-structured interview process. The responses were recorded and typed verbatim. The individuals with stroke received $25 after the interviews and after reviewing the transcript. So how did I confirm the validity and the reliability of the data collection process and the analyzation process? First, there was member checking. The individuals with stroke corrected their transcripts for content accuracy and meaning after I listened to the recordings and corrected the transcripts. I basically mailed them the transcripts, and they were free to write in information or cross out things that was not right, and they mailed them back to me. There was a peer review process in which I and the research assistant independently reviewed the transcripts using a framework approach. And from there, we found common themes in the data and came to agreement about those themes. So let me delve into a little bit more about what is the framework approach. This is a process in which you become familiar with the data. You have to listen to the recorded interviews. You have to reread the transcripts, and you're taking notes during this process so that you can really become intimate with the data and be prepared to have a discussion about the data with the other person who's also going through the same process. During our discussions, we group redundant similar issues, and then those issues become concepts, and then we take those concepts and bring those concepts together and put them under a theme. We sort the similar issues, we sort the similar concepts, and we sort the similar themes. And once you've sorted the similar themes, they become bigger, broader themes. Data indexing is the analyzing what's different about the issues, concepts, and themes, and what's similar within each category of issues, concepts, and themes, and what's different between the issues, concepts, and themes. So then you begin to have these categories of topics, all right? And once you have these categories of topics, new terms are created to represent the differences or similarities. This is known as charting. And this really adds to the robustness of the final theme that will be emerging from the data that was collected. After that, there's a data mapping process where when we have our final theme, we can go right back to examples in the data and say, this theme came from this piece of data and this is why. And when you do that interpretation of why, it helps to support the charted teams. So after peer review, there's reflexivity. This is an audit trail detailing the data collection and the analyzation process. And we do this by journaling. And we do this to recognize our biases that may have occurred, because you just don't want to make assumptions about what something appears to be in the data. You have to go through this process of this framework approach. So during our journaling, we would document the participant behaviors as seen in the video, their responses to questions, and certain nuances on how they answered the questions. The journaling helped for us to generate insights while we were reading the transcripts and viewing pictures and videos multiple times. We found ourselves saying certain things over and over again. And then we had to ask ourselves, why are we saying that? Is it objectified in the data? And then we use all of this information during our discussions with each other during the coding process. So again, when we were going through coding, using our framework approach, we had evidence about what was really there versus relying on what we thought or our intentions or our feelings. So it really does limit your biases about the data. So what was the results of our research process, starting with the participants? So the healthcare providers distributed all of the flyers and the information about the study, and 5 individuals with stroke contacted me. And I found that only 2 were eligible. Participant 1 was a 62-year-old white male, left CVA with right hemiplegia, 25 months post-stroke, and wore a solid ankle AFO for about 4 to 8 hours a day. Participant 2 was a 37-year-old white female, right CVA and left hemiplegia, 21 months post-stroke with a hinged AFO, and she wore it all day during the waking hours. So I just want to demonstrate here that even though we had a small set of participants, they were quite diverse in terms of gender and age, type of CVA, left versus right, and then type of ankle foot orthosis. So after the data analyzation process, 6 themes emerged from the data after our framework approach. The first was AFO Impact, and this was participant 1, who was the male. He says, was the only way that I could walk, meaning the AFO usage. It helped me a good bit in the beginning to walk around the house, and I then graduated to the yard and the road. Second point, but lately it's more of a hindrance because it doesn't allow my foot to bend and allow my leg to walk upstairs, anything like that. Third, I had a problem with my foot was crooked and it started to straighten up. I got a blister because of the brace, and he had to, that's when he made that bigger. So he's talking about an area on the brace that the orthotist made bigger to accommodate the blister that had developed on the foot. And last, I have to wear a half size bigger shoe to get it to fit. Well, it throws my other foot off because I'm wearing a half size bigger shoe. For participant 2, these were her reported concerns about the AFO impact. Point 1, I feel better having it on than not anything on because I just don't feel like my ankle is not very strong enough to walk properly without it rolling, I guess. Point 2, I guess my tibia and fibula moving forward over my ankle to stand and project forward. So the AFO impacts that ability to move forward. Also to propel forward, or however you want to word that. I wouldn't say it rubs, no, but I do sweat in the calf part of it and it sticks to the skin. So the AFO has some impact on the integumentary system. It would be nice to wear regular tennis shoes, flip-flops, or, wear a little sundress. It was about 7.5, and these are 9.5 wide. So with the last 2 points, the AFO impacts what she feels is appropriate clothing wear and shoes. And then she has to buy a larger shoe to accommodate the AFO. In summary, for both participants, the AFO had positive and negative impact on functional mobility skills, but negative impact on the integumentary system and apparel. The second theme was innate AFO properties. For participant 1, he said, it's very rigid. It will not let my knee bend at all. Sitting, what it does, where it wraps around my leg here, up here, it won't let it. When I start dropping my foot, it puts pressure against the back and it won't let it drop. So basically he is saying that when he sits, his foot is up in the air and he can't let his foot rest on the floor. And the last point, but that brace is cold by itself. So in the winter time, it was cold against his skin. For participant 2, I guess ankle movement, yes. And I wanted to have a little discussion about this because the AFO for participant number 2 was set in plantar flexion, and she felt that the AFO itself contributed to her ankle movement, the lack thereof. And because of her shape of the AFO and her foot being plantar flex, she had to have extra shoe heel height added to the AFO so that the foot would have contact to the ground through the heel wedge that was on the outside of the shoe. So she didn't see her foot movement in the position in plantar flexion as a weakness problem, but a problem that the AFO was stiff and it was keeping her in plantar flexion. Her next comment was, it's big, it's just big and bulky and heavy. Third, well, the hinges don't help fit inside the shoe. And then I asked her about the strap, and she said, well, I don't like this one. Was long enough to begin with, but it lost its stickiness to stay on. So she had a figure 8 strap around her ankle, and it lost its ability to stick the Velcro in the loop. And if you saw it, the tongue of the shoe always got in the way for that strap. So I wanted to point out that the participants didn't have any problems with the AFO properties such as breaking, cracking, or losing its shape, which are positive features inherent to the AFO. But the negatives was its stiffness, the temperature, and the AFO accessories. The third theme was self-perceptions. So participant 1 said, doesn't look very user-friendly. It looks very uncomfortable. And he was referring to the picture. And then in his self-portrait, he says, don't look comfortable in that picture. And then for the video, it hindered my leg and knee and hip. It supports the back of my leg. It allows me to walk. It gives me support when I need it. Well, it looks like I'm being careful, and he laughs, going up and especially going down. But it's not that I'm being careful, the leg won't move. And when he said the leg won't move, what he really wanted to say was his ankle needed to be more flexible and his knee needed to bend more to negotiate the ramped area and the steps, but it couldn't because of the rigidity of the solid ankle AFO. The AFO as an external feature represented an inherent part of their self-image, for both of them, but for participant 1. And he was quite aware of his abilities and his inabilities and related it to the AFO. So when participant 2 looked at the AFO, her response was ugly, sad. And then her self-portrait, I don't know, it's just sad that and she had an aha laugh, she just laughed. I have become, this is my life. And third, for the video, yes, my left side seems pretty stiff. Not as much ankle movement or knee motion, I guess, as the right. And last, I know I need to wear it in order to prevent injury. Do I like the looks of it? No. Do I like the looks of my shoes with the heels? No. So again, for participant 2, although there was perceived benefits of stability provided by the AFO, her overall perceptions about the AFO and herself while wearing the AFO and doing a function in the AFO were not positive. So then I looked at self-perceptions and what the participants thought how others perceive them. So for participant 1, well, if I'm in a store, they kind of look at me kind of funny to see what's wrong. And participant 2, it draws attention. I draw attention, period, end. I just think the look of me in general is not your normal. I mean, you can tell that there is something the matter. So again, in thinking about how they perceive themselves in the AFO And when others perceive themselves in the AFO, they had more negativity about themselves when others were perceiving them. But when what their self-perceptions about the AFO for themselves, they had positive and negative comments. And the positive was that it provided some stability to engage in an activity, but then it was also limiting. So then we come to a point, how is it that they communicate these features, these issues about the AFO to either their physical therapist or their orthotist? So participant 1 said, I didn't really have much to say in it. It was, I either have that and walk with it or not walk at all. The only thing we had a conversation about, I would probably have to have a half size bigger shoe or one I could take the insole out of. And that was the only thing. For participant number 2, typical shoes, they said it probably wouldn't fit. Just taking out the insert on the left. Third point, keeping my ankle stable, and there was a long pause. I timed the pause. I guess it kind of helps me with my toe raise and rolling my ankle, laterally, I think. And then I further went to ask her, does the AFO hindered participation in activities? And she said, it hinders, I would say, my shoe choice. It hinders the shoe choice. And because it hinders the shoe choice, then she cannot participate in the activities. But if you wanted to go to the grocery store or go to church, you could wear the AFO with the sneaker. But to her, if she didn't have on the appropriate shoe for the appropriate to the context or situation, it was a hindrance. So I wanted to reiterate that there was no discussion with either individual with stroke regarding which shoes do you typically wear, or how would the AFO fit in a shoe that you normally wear, or how would it be appropriate, the AFO would be appropriate for your typical daily activities. No one, the orthotist nor the physical therapist, asked those questions. No one asked the participants their opinions on how the AFO should look. However, the common sentiment was that it allowed for the basic function of walking. The next theme was AFO modifications and maintenance. The only modifications or maintenance for participant 1 was related to the blister that had formed. He heated it up and moved it out away from my foot, and then he put a piece of padding. For participant 2, this ankle strap was added to it. So that was a part of the modifications process for her. Then I asked a question for further explanation. I said, what do you think the strap purpose was? I don't know. I don't have a clue, really. I guess my therapist did not like the way I was walking in it. To keep my foot and back in the heel, probably. And I just want to add at this point that participant 2 was a healthcare professional. So she knew some basic understanding of the human body, the names of bones and joint movement to a certain degree. I then asked her about her heel lift and what she knew about getting a heel lift on the outside of her shoe. And she said, to get a better bend out of my knee is what was told to me. Something like a 9% bend or something. I couldn't tell you. I mean, no, I don't feel like my knee is where I want it to be by any means. And then continuing on, not really. I think I mean, no, I don't notice that much of a difference. And so I further delved into asking her about her knee, has it changed in bending with the heel lift? So the next thing that came about was future recommendations. If the individual with stroke had the opportunity to tell the PT or the orthotist what should be done differently about the AFO, these were some of the responses. So participant 1, it doesn't have all that plastic. What's on it? That's made up. And for him, he thought it was just too much plastic for what the job of the AFO had to do. Well, it could be a lighter, if a lighter material, it could be thinner, and it could flex. There's no flexibility to it at all. And again, remember, participant 1 had a solid ankle AFO. And then he goes on to say it has to be smaller. It cannot be, there's too much area where it slides in your shoe. There's too much area it takes up. For participant 2, different straps, I guess, I don't know. She had an issue with her straps at the ankle staying, adhering to each other. And I think that had a lot to do with the tongue of her shoe. For the ankle strap, I would say not so high up on my leg. Again, it was a figure 8, so it came above the malleoli. The ankle stability seems okay on it. Well, I guess moving the straps so I have more ankle movement. And there was a long pause, 7 seconds, and lower leg movement. So when you think about the figure 8 across the dorsum of the ankle, it compresses on the anterior tibialis tendon and the extensor digitorum longus, hallucis, as well as the digitorum, but more so the hallucis tendon medially. And so you prevent this activation of possibly getting the foot to lift up and the toe to extend. It also prevents, if any ability to do so, of the tibia coming forward. And then she responds, the tibia fibula to get a better bend, I guess. And that was her way of saying that she wanted better ankle movement. And then we talked about the foot clearance problem for her. I would say it could be better getting caught under the steps, the things with ledges or what have you. Remember, she had a plantar flexion, a foot that was in plantar flexion. In order for her to have weight bearing stability, there was a heel wedge added, and she was told that having this heel wedge because of her plantar flexion would help the knee bend also. Again, she answered, she had her recommendations for different aspects of the AFO, but appeared when we looked at her videos again and how she was answering the questions, she was unsure if it would have impact. So these were some things that were said in common for future recommendations by both participants. And then I asked them some specific questions, and these were the responses. Both participants thought that there should be shared decision-making for the AFO fabrication process. And they both felt that the opinions about footwear and the activities performed should be valued by the therapist and the orthotist. And those things should be taken into consideration when fabricating an AFO. And so I asked participant 2, well, how should the shared decision-making and this hearing of the opinions happen? And her response was, well, just asking questions, questioning what they normally wear, shoe-wise, and their activities. And then I said, so why is this important? Well, that's part of your everyday, well, that's part of being alive. And she just had this laughter. You're normal. And at that point, I realized, like every other individual with stroke, this perception of having to be normal is so important but they're up and walking, but there's still this thing about the appearance of normal and being normal. And then I posed the question, well, when should this shared decision-making process, or when should this questioning about your opinions of what you value and your shoe type and your activity lifestyle, when should this occur? So the response from P1, me, probably it was a good year before I realized that the brace was hindering me more than helping me. And the orthotist he said that the orthotist should meet with him again after wearing it and understanding the problems associated with it. So I just want us to think, what is the turnaround time for the orthotist and or the physical therapist setting a schedule and say, I want you to wear it, write down what problems you have, and then when you come back, we're going to address these problems. Is it that they're only supposed to come back when they have a problem? So participant 1 didn't see the AFO as having a problem when he was doing higher level mobility functional skills, and he realized the brace was hindering him. So that was a year. So again, it just says, what's the timeline on how we can help our clients improve by modifying the AFO. So this leads us into some interesting points of discussion. So let's discuss the AFO impact first. The AFO provides a benefit for safe walking, but it becomes a barrier to performing certain activities requiring specific joint movements, such as squatting or walking up and down an incline. And this was particular to participant number 1. Also, it creates a sense of abnormality. For example, when sitting, the foot cannot rest on the floor, as we saw with participant 1. There is some misunderstanding if whether the AFO is preventing the return of movement, despite it providing stability to engage in activities for exercise. Participant 2 was using an elliptical machine. So she was able to engage in the activity because it provided stability because her ankle wasn't rolling out. But she thought the shape of the AFO and her foot being in plantar flexion, the stiffness of the AFO into plantar flexion, that's its shape, was preventing her from getting ankle motion return. She didn't think that it was a problem of ankle weakness. And last, it limits choice for clothing and shoes, particularly the shoe situation for participant 1, but shoes and clothing for participant number 2. Moving on to the discussion regarding AFO properties. There is an ambivalence towards the AFO long-term use if it's not user appropriate, despite being able to function independently with it. So when I say user appropriate, participant 1 couldn't take advantage of proper kinetics and kinematics for incline walking up and down because of the limitations of the brace. Both participants raised issues of AFO stiffness, contributing to the lack of movement at specific joints. And particularly P1 mentioned compensating at his hip for lack of movement at the ankle. Now, remember participant 2 said that her foot kept getting caught under ledges and going up and down, going upstairs. However, if she was able to bend more at the hip, she probably could have gotten foot clearance, even though her foot was set in plantar flexion. So again, her understanding of weakness, all right, may be a contributing factor that she is putting the onus on the AFO. and was more a problem of weakness than the AFO itself. So when you look at the research, it supports decreasing AFO stiffness, which will increase ankle range of motion. But just because you decrease AFO stiffness does not mean you increase ankle force production. Ankle force production has to do with gains in strength. So it's two separate entities, two separate constructs. Just because you're going to increase the flexibility at the ankle doesn't automatically mean that you can pull your foot up. The next discussion point is communication. There is this issue of not knowing or appreciating what is impacting stroke recovery. So you have to look at the gains in function versus the improvement of weakness. And this may be a delicate subject to communicate among individuals with stroke and healthcare providers. So for the therapist, are you really taking the time to explain what weakness is and why it may not return, and how you still can function and be a whole person in terms of your contributions to your family, your social roles, and just participating in life? For the orthotist, are we taking the time to say, I realize you can't pull your foot up, but the ankle foot orthosis provides some stability so that you can walk faster with your dog. Now, what is it that we can do to the AFO to make it more comfortable as you walk with your dog? Okay, so I just think it's a communication issue about stroke recovery in terms of function, which is walking, and improvement of weakness. So discussing impairments in realistic motor recovery, and in turn, modifying the AFO to accommodate the different aspects of motor return, and I would say function, should be a shared decision-making process via communication. And I think this needs to be an ongoing communication between the therapist and orthotist. The patient should be told that feel free to call us at any time so that we can set you up an appointment if you notice changes. And I'm sure we all say that, but it really would be a great marketing tool to have a yearly appointment or a 6 months appointment and a checkup. And insurance will cover those if we have the justifiable needs for that. I think AFOs can be modified so that we can accommodate either the change in impairment or the changes in function. Last, research indicates that the perspectives of individuals with stroke are not considered during the process of AFO prescription, fabrication, or trial use of the AFO. Now, we all know that the doctor writes an order for an AFO, but does the doctor really know the intricacies of AFO fabrication like the orthotist? And then impairment and then gait analysis like the therapist, the physical therapist. And I have to give it to my orthotist. They know gait analysis and gait impairments for kinetics and kinematics and function just as well as physical therapists. And if that's the case, two of us need to put our heads together in order to do what's best for the patient. So next is our discussion about AFO satisfaction. So the orthotists are more adept at the technical aspects of the AFOs, but often do not consider how those technical aspects are functioning for the individual with stroke. And those individuals with stroke don't know how to explain to the orthotist well enough the technical problems they are having. They're just saying what they can and cannot do, and they don't explain it in the details of the task in which are occurring. And so sometimes it leaves the orthotist guessing at what to do with the AFO. This is when the physical therapist comes in. With all this technology now, we should be doing videotaping of our functional mobility skills with our um, clients. We should also be able to give the orthotist range of motion, be it active or passive, and manual muscle testing scores, and it can look at eccentric uses of the upright motor control test, because it does a whole lot better in terms of function as opposed to a number, which is isometric with your manual muscle test. And we should be able to talk about these issues so that we can better fabricate an ankle foot orthosis based on the impairments. Camp did a wonderful survey about AFO satisfaction and use. And these are some of the results. AFO users who were dissatisfied said their comments were not used to improve the AFO. AFO users who were satisfied reported AFO were problems related to design and conditions under which they use their AFO. So they had problems with design and the problems that the AFO caused under certain conditions during activities. And then last, it was reported that negative comments were not used to improve AFOs. And you want the AFO to be patient-oriented in design, fit, or use. I really changed my perspective on how an AFO should look and how it should function when I had an Atlanta socialite who told me she doesn't own a pair of sneakers. And when she goes to Ulta for tennis, she doesn't play. She goes there as a spectator. And I remember going with her to Neiman Marcus to buy a pair of shoes that had to accommodate her ankle foot orthosis, which had to be the least obtrusive one that we could make that would provide her stability and fit in her nice black low-heeled Neiman Marcus shoes. Another female commented to me, if they could just make the AFO my flesh tone, and so it would blend in and she would feel more comfortable wearing a dress. So again, the AFO has to be patient-centered. Just like we practice patient-centered healthcare, the AFO has to be patient-centered. So moving on to this discussion about AFO impact on body esteem. So self-awareness is a key concept in knowing if one is improving in terms of function or there is a change in impairment, and in this case, weakness or strength. This self-awareness or body perception is known as body esteem, and it is related to independence. Stroke recovery may be viewed as returning to what is perceived as normal by individuals with stroke. Despite being able to function, which is the return to walking, a lack of motor recovery or strength gains may be viewed as not normal. So with this body esteem, there's a mismatch. They are valuing functional recovery less and motor recovery more because they're perceiving the body as an object requiring an AFO to pull up the foot, all right? Rather than perceiving the body as a process to function with purpose. When you can get up, walk, sidestep in a church pew, genuflect at the altar, turn to reach your coat, your body is moving with purpose, all right? It's functioning, it's achieving a process. There's a means to an end because it's associated with something intentional. That is function, but normal is being objectified as in you want something to specifically work, like the foot to come up, which is a sign of strength. So this study had two major limitations. First of all, with this small subset of population in this area of the country, we cannot apply these findings to other individuals with strokes. What was said was unique to these participants. Last, this was a very small study sample. Recruitment and location was an issue. If I was working in an inpatient or outpatient rehab center that had a large population of individuals with stroke, I felt I would not have any problems for recruitment. But I was in academia in a rural Appalachia area, and it was hard for me to partner with, build trust and relationships with healthcare providers who had common experiences, and orthotists, I tried orthotists too, with individuals with stroke. So in conclusion, I would like to discuss a few things. These were two very different individuals with stroke, and they had more similar thoughts about the AFOs than differences. The AFO had a negative and positive effect on functional mobility. There is an ambivalence towards AFO use if it did not allow for specific body movement. And the lack of body movement may have been linked to the impairment of weakness. And that I feel was a consideration for participant number 2. But for participant number 1, he knew he was getting stronger, but the AFO was holding him back, and he felt he was getting stronger because he could do more challenging activities. These individuals with stroke demonstrated insight of how the AFO could be a better functional support system. They really had some self-awareness about how the AFO could be improved for them. But these individuals with stroke lacked an opportunity to share their opinions regarding their AFOs. So for future research, I am going to have to repeat this study with more individuals with stroke and determine if these are similar or different findings from this study. For now, I think I have enough information to apply the findings of this study to fabricate an AFO based on the comments from these participants. And I'm in the process of doing that. And I think in the end, there needs to be a development of an AFO evaluation process that includes the opinions of individuals with stroke. I know we all take a subjective and a patient history, but are we intentional about asking the questions and finding out what's important to the patient? Or we just look at the impairments because we've taken all the measurements and we say, this is what you're going to need. So I want to say thank you for attending, and I look forward to seeing everyone on March the 13th at 11 a.m. to have a further discussion on the communication of orthotists, physical therapists, and individuals with stroke about making a better patient-centered ankle-foot orthosis. Again, I would like to thank the Ohio chapter of the American Academy of Orthotists and Prosthetists for giving me this opportunity to present my research. My current contact information is jvbrown@csuniv.edu. Thank you so very much. Thank you.